Welcome to the Observed Day podcast, the show where we celebrate the days that matter. From holidays to meaningful observances, we bring you inspiring conversations, stories, and ideas to make each day count. Whether it's raising awareness, learning something new, or simply sparking joy, this is your space to explore the calendar in a whole new way. I'm your host, Wisdom Okonkwo, and I'm excited to share today's observance with you. Let's dive in. Today's conversation is grounded in the International Day for the Elimination of Racial Discrimination, or exploring what that idea looks like far beyond the calendar date. My guest, Eugene Manley, is a cancer scientist, nonprofit founder, and health equity advocate who works at the intersection of biomedical research, AI, and lived patient experience. As a Black healthcare advocate, Eugene has seen how bias and discrimination show up not just in policy, but in medical records, algorithms, and exam rooms, including his own. Through his nonprofit SCHEQ and his work with patients, caregivers, and future scientists, he focuses on turning complex systems into tools people can actually use. This conversation matters because discrimination doesn't always look loud. Sometimes it's embedded, invisible, and deeply consequential. Welcome to the podcast, Eugene.
Thank you so much for having me on, Wisdom. I'm looking forward to the conversation.
Yeah, I should be thanking you for accepting my invitation. Yeah. It's good to see you. Yeah. When you think about the International Day for the Elimination of Racial Discrimination, what personal experience first comes to mind that made this issue feel urgent rather than abstract for you?
Well, I grew up inner city Detroit, but I spent a lot of my summers in southern West Virginia as a kid, and you don't realize that stuff is what it is until the day you face it yourself. And
Yeah.
parents, any black parents try to hide their kids or try to keep their kids from experiencing it, but unfortunately you just never know when you're going to experience it first, and then it will be a lifetime of dealing with um, discrimination, slights, and you just have to determine best how to proceed. But my first instance was my grandparents were the only black people in their neighborhood in West Virginia. And when I would go down there in the summers, none of the other kids in the neighborhood would want to play with me. So if I wanted to play with people, I had to do the 25, 30-minute walk to the other side of Beckley, West Virginia, to the black part of the town where my aunt was. And then the kids over there would play with me. So got to learn that around 5 or 6.
Wow. Wow. That's a childhood memory.
Yes.
Wow. You know, later on you've experienced medical racism first and after surgery. Can you tell us about that experience?
Okay. So that experience was very interesting. I had a slip and fall and fractured my ankle, and I was in a boot for 7 weeks, 6 or 7 weeks. And then after the fracture, there was still so much damage in the foot that we still needed to do reconstructive surgery. So
Yeah.
the issue was not the surgeon. The surgeon was great. They were the chair of podiatry. It was the rest of the hospital staff that collectively decided that since at that moment I was on Medicaid and apparently perceived to be poor and uneducated, uh, that's my take on it. They decided to lie and misrepresent things in the medical records, and this completely prevented me from getting the skilled nursing that we asked for. So the
Yeah.
surgeon and I had agreed, because I had asked, could we just get skilled nursing, because it's a non-weight bearing surgery. You're supposed to be non-weight bearing and in a cast for 6 weeks, and it is ungodly painful. I don't think I've been in that much pain since I tore my ACL. And so I was prepared for the pain, but because I live alone, I don't have any family out here.
Yeah.
And my friends are at work. I didn't want to really burden anyone. And I knew with this kind of procedure that, just based on how I was after the fracture, I could not walk in my apartment. I couldn't clean. I couldn't
Yeah.
shower. I couldn't use the dishwasher. So I knew I just needed some support for those first few weeks. However, the physical therapist in the hospital came in about 36 hours after surgery to do a skilled nursing assessment. but she had horrible bedside manner, was rude, dismissive. And now, mind you, I'm in a ton of pain and on opioids. And I'm sitting here and I can sense her energy. And I'm like, oh, it's going to be one of these. And man, was I correct, because she tried to force me to use this walker. Now, mind you, I'm 300 pounds. I have on the left, now the surgery's on the right foot. Now, I have a left knee ACL reconstruction. I have flat feet on the left foot, but she wants me to stand on this one leg, hop, and keep this right leg that I just had surgery on dangling, which means it is,
Oh,
now mind you, this is a fresh surgery, so all this blood is rushing,
yeah.
and I'm on painkillers, and you want me to try to stand and hop. I was in so,
Wow.
and what was even more upsetting, and I didn't realize this till 3.5 weeks later, was that she wrote in the chart, "Patient has no pain and can ambulate." I didn't see, and now because I was not reading my work because I was in so much pain, I didn't read that right then. And then continued stuff in the hospital, like, the nurse that second day, that later that evening, tried to give me an early discharge notice, and they had it written for an earlier time in the day so it could still pass insurance muster, but they didn't give that to me till 6:30 p.m. But they wrote it for 9:30 a.m. and I said, I'm not signing
Oh,
this. um
yeah.
and they wrote patient refused to sign, which I did, and then they put
Yeah.
relationship itself, but then the time was 9:30 a.m. instead of 6:30 p.m.
Ooh.
However, by state law, you have to give a patient that notice at least 24 hours before a discharge, and that was 6:30 p.m., but it was not 9 a.m.
Not 9:13. Yeah.
and and I still hadn't seen a caseworker or social worker or any of these things that I'm supposed to see before you're trying to give a discharge. And mind you, it is also a Saturday evening. So, guess what? Insurance will not be open
Yeah.
on Sunday. And then a couple of days later, the hospitalist is asking me about my ability to pay for skilled nursing. Now, at this point, I'm just frustrated and angry because I'm like, are you all just trying to avoid any guideline concordant care and asking questions that are not medically relevant or needed for the assessment? And then I realized they were basically icing the surgeon out of the medical record. So, because he didn't have direct admitting privileges, he couldn't see what they were writing in the charge. So, and then at the same token, because I said I wasn't going home, they said, well, if you go home, we'll get you a home aid, which I thought they would, but that was because I hadn't read the medical records. And so,
Yeah.
the surgeon tried to get a peer to peer to appeal the skilled nursing denial. And the insurance said, well, why did you wait 5 days to appeal? Well, the only reason he waited 5 days is because PT would not answer him. He had to
Yeah.
complain to the hospital on day 5, and finally PT answered. And apparently, they felt they knew more than the surgeon. But because PT wouldn't change their assessment that patient had no pain and could ambulate, and OT said patient could ambulate, this meant that insurance could not overrule the assessment, which was completely false. So I ended
Yeah.
up having to go home with basically no aid. If the surgeon hadn't appealed to get me at least 3 days, I would have been home with nobody at all, which I really didn't have anyone anyway. So, it was pretty harrowing. And then on discharge, they even wrote in the chart that patient has a caregiver, which I do not. So
Yeah.
when I say it was a litany of misrepresentations across the board, I was rather appalled. And then one day they hit my foot 4 times and they were dealing with the patient in the next bed, and that's the only time I yelled at them. And then they put in the chart something, I don't know what they wrote. It was something I couldn't read.
Yeah.
So this goes to show you that basically healthcare, sadly, is, if they think you are rich or you have money, you will get treated way better in healthcare than if they assume or think that you are poor and uneducated. Yes, I happen to be on Medicaid because I launched a nonprofit, but I have just never seen such blatant misrepresentation and coercion use against a patient. And so it made me realize that patients going into surgery need to have a proxy with them in real time, and how you can file things to make sure you try to hold staff and hospital systems accountable. So sorry, that was a
Well,
longer story than you probably wanted, but that
this
is
is an
in
interesting
essence
story. Yeah.
what happened. But and the problem is, if that happened to me, now mind you, I'm a PhD and I have a background in biomechanics, so I know this stuff. If that happened to me, who knows how to advocate, but really had no voice at that time, more concerning is what are they doing to all the other poor, diverse, underserved patients who
Yeah.
don't know how to read medical records, who don't know why they're getting pushed out, and who end up probably back in the hospital with readmissions or injuries or falls.
Before we dive deeper, I'd love to invite you to join the Observe Day newsletter. Every week, I send you highlights of upcoming observances, creative ways to celebrate, and behind the scenes extras from the shows. It's the perfect way to stay inspired and never miss a meaningful moment. Sign up today at observeday.com/join. That is observeday.com/join. Now let's get back to the conversation.
And that is more worrying than what happened to me.
Yeah. Well, what's a common misunderstanding a lot of people have about racial discrimination in healthcare that you wish more people could see clearly?
The this is an easy one. Well, at least for black individuals. People always say,
Yeah.
"Well, that doesn't happen," or "That never happened." And for black patients, we always are ignored or disregarded or disrespected, and it's just no one usually knows how to report it or talk about it. I just luckily work in health and know how to advocate and speak about these issues, but many people don't even have this opportunity, or they're afraid to speak about it.
Um, you've had your own fair share of discrimination, and how do those lived moments shape the way you show up in rooms where decisions about technology, policy are being made?
Well, this is very interesting. Because when you're in these spaces, I go in these spaces from the lens of thinking who is not present, who is not represented. Are things we discussing or implementing going to impact patients with greatest disparities or inequities? And so I
Yeah.
try to make sure we think about and account for those groups so they aren't unnecessarily excluded. Now, if I'm running a meeting, it's different than if I'm a participant or panelist, but I always try to schedule and make sure that the voice or voiceless, more so, have their needs and concerns addressed.
I'm curious, from your own perspective, why does racial discrimination continue to persist in healthcare systems, even though they claim uh, to be evidence-based and objective?
Well, this is, if we go longer back, if you think about the history of race in medicine, one race is technically still a social construct, but certain people have used race as a proxy for assuming certain intelligence of people. In the past, black women were used for medical experimentation without anesthesia. Like basically, whole history of gynecology in the U.S. was based on a guy doing experiments on blacks and maybe black slaves who had no consent and no anesthesia. And you see that even though we technically are more advanced in that today, we still don't have a diverse workforce that reflects patients with disease. In some instances, medical school is still about, how many test prep courses you have, how much money can you afford to pay to get that schooling. And many
Yeah.
people come from families that are already well off and educated and can do this stuff, but these people often do not, well, I don't want to say, these people do not usually come from the communities that are underserved or don't have represent or don't understand how to navigate care. So that is that is sort of what we try to deal with and address.
Well, one of the things that's trending and common now is AI. How do algorithms and AI tools reflect the same biases we see in human decision making even though they are presented as neutral?
Well, this is a very interesting thing. There's an adage when you look at data. There's a saying, garbage in equals garbage out.
Garbage out.
And if we conceptualize this means you could make the algorithms are based on the data that we currently have. And most of the data we have is not built on
The
diverse
flawed. Yeah.
populations, or they aren't included in the samples, they aren't included in the design. And so the data that we have is biased by nature just based on what's out there. And then if
Yeah.
you're using that as your basis for making healthcare decisions and care delivery, then you're going to drive more of the discrepancies. And that's really the challenge. So yeah,
Well,
that's what we say.
well,
Yeah, so garbage in,
yeah.
garbage out. But if you include these populations or think about this and do due diligence, you can mitigate some of the bias in the algorithms, but you have to do that from the beginning. You can't come late, oh my God, we missed it, or someone sees you have something that's going to screen breast cancer for women with dense breasts, but your training set and test set were all affluent white women from a suburban hospital, and they said, well, we have a solution with this algorithm. And I know my friend did this specifically at a meeting and said, well, where are the black women in this study? Because we know that black women have dense breast and they have
Yeah.
much greater risk of breast cancer. And so if you have a whole training set and test set that does not even include black patients, you have a product
Yeah.
that's a bingo, doesn't work. So this is sort of the flaw of sometimes these LLMs. If you aren't thinking and doing your due diligence to include the groups that have the disease, then it's not going to work.
Why is representation in research, clinical trials, and STEM careers so central to eliminating discrimination in long term?
I think this is a very important question. A lot of people say, well, we want more diverse trials. And on one hand, yes, we need diverse trials, but if we don't have a diverse trial team, a diverse trial site, a diverse set of trial coordinators that actually have that lived experience, then it's going to be hard to get those in these communities to understand. And on the
Yeah.
other token, if we don't get more of the diverse kids from these communities to go into research and then get degrees and then contribute to the medical workforce, we still are going to exacerbate disparity. So we have a whole big gap between those going into the workforce, well, getting degrees, and then those staying in the workforce to do the work. And that's where our biggest challenge is. If we don't have a diverse workforce with lived experience and understanding and empathy, it's going to be much harder to move the needle. And as you know, there's enough data to show that diverse teams tend to produce better products, have reduced groupthink, and better decision making.
How does your work at um,
Check.
SCH check SCHEQ, that's check, challenge the way? What does check even mean before I go on with the question?
So that's the short form of the acronym. That's the acronym for STEM and Cancer Health Equity.
Okay. How does check challenge the way institutions usually think about health equity?
I think of this from a systems lens. So by definition, I think health equity is about intentionality. And by that, I mean that you have to be intentional about creating an intervention for a group or groups that are experiencing a disparity or inequity so that they get to the same baseline as the majority population. That doesn't mean the population has to be a white population. It could be you have disparities in Asian females with no history of smoking that get lung cancer. It could be rural. It could be veterans. So it could be any population, but whatever you're designing an intervention for, you have to make sure it's specific for the group that's experiencing inequity so they can have a positive outcome. So in terms of what we do, that's sort of, we think about all the things we do in that lens. So if we get more diverse kids in STEM fields, then maybe we can get more to go into these research spaces and clinical trials, and then the patients might be able to get more guideline concordant care and find more people that look like them. Because
Yeah.
when you see people that look like you when you often never do, it can be for some people a great relief, and then okay, I can actually speak about what I really want to say or feel, because you're not worried, was the doctor going to listen to me, or are they going to disregard me?
Yeah. What do you hope? What's the ideal picture you have in mind for the healthcare system?
For the ideal picture, I want people to know that they have the right to ask questions, they have the right to ask for second opinions, and they also should make sure if they're doing surgeries that they should have a proxy with them to protect them in case they're on, medications and can't really answer questions. So that's, I think that's probably three things. So,
Yeah.
but
Yeah.
you are definitely within your right to ask for second opinions and to get things clarified if you do not understand them, and you should not be afraid to ask that stuff.
Yeah. A question that's been lingering in my mind is how can individuals, because you spoke about it in passing, especially patients and caregivers, recognize discrimination and also point it out without feeling powerless or being dismissed for like what you saying, you don't know what you're doing.
That's tricky because sometimes you see it overtly, sometimes it's very subtle. Like in my instance, it was, if I didn't know how to read medical records or charting, I would have not noticed any of it. But
Yeah.
I'm attuned to people and how they act and behave. But I just still never expected it to happen in my medical records, which for me is good because that meant it was documented what was fabricated. But
Yeah.
that means likely they assume that many patients don't read records and would never call it out. But I'm not that kind of person. I'm stubborn.
Yeah.
So, did I answer your question? I forgot. Did I answer?
I guess the answer I will take from that is read your medical records.
Yes, read your records or have someone do it in real time. Like I said, because I had surgery, I really couldn't read, and I wasn't expecting the stuff to be in there. That wasn't even. I don't even know if I would have read it to that degree if I was alert, because I was just going through so much at the time.
Thank you so much. Where can listeners learn more about the work you're doing and also connect with you?
Okay, you can find SHEQ on https SHEQ.org. Our social media handles are STEMMCHEQ. That's Instagram, Facebook, LinkedIn. And if you want to follow me, you can follow me on LinkedIn, Eugene Manley Jr. And I'm on Blue Sky. I don't do as much on Blue Sky, but I do some stuff on Blue Sky. And we have a donate button on the website if you want to donate, and we have resources if you want to learn about our resources. And you can email info@shec.org if you want us to develop a workshop or a training program.
Well, thank you so much, Eugene. I'll put the links mentioned in the description. And thanks for just sharing your story and for the work you do.
Thank you so much for having me. It was a great conversation, and I hope some people will learn something that they can use in their healthcare interactions.
Yeah, of course. That's it for today's episode of the Observe Day podcast. Thank you for spending your time with us as we explore today's observance. If you enjoyed this episode, be sure to subscribe wherever you listen to podcasts and share it with a friend who'd love to celebrate life special days too. Don't forget to join the newsletter at observeday.com/join for more observance stories, tips, and updates. Until next time, keep finding meaning in every day.